Welcome to Louisville Lectures, PEM Little Lectures.
Hi, I'm Lehto, and today we're going to talk about G-tube replacement. G-tube dislodgement is one of the most common complaints associated with G-tubes seen in the ER. And the good news is that most are able to be replaced by an ED or PEM physician or by a resident or fellow along with the help of the PEM physician. So when you're seeing a patient with a dislodged G-tube, there can be a few questions that are helpful to ask during your history taking. The first is how long the patient has had the G-tube. And the reason we ask this is because tubes that have been in place less than 4 to 6 weeks have a risk of false tracking. And so at this institution, if they've been in place less than 6 weeks, we typically defer to the team that placed the tube, usually surgery, to have them come replace the tube. Now, if it's been longer than 6 weeks, then the tube has epithelialized and there's less risk of false tracking and can be safely replaced at the bedside by the ED team. You also want to ask how long the tube has been dislodged. Did they see the patient pull the tube out, say, just before they got here? Or did they last see the tube last night when they hooked up for an overnight feed, and this morning when they went to check on the patient, they noticed it was dislodged? And the reason we ask this is because the tract will begin to become stenotic within hours. And so it can be helpful to kind of guide how difficult we anticipate this replacement to be. You also want to ask if there's anything in the stoma. Some families will have a replacement G-tube at home and they may have already replaced it and just want it checked out, or they may not have had a replacement and they may have put the broken one back in or maybe a fully in place. And again, we want to know if there's anything within that stoma because, again, it becomes stenotic within hours of it coming out. The last thing you want to ask is the size of the G-tube, and there's two components to the size. There's the length, which is in centimeters, and the diameter, which is in French. And on the tubes we use, the mini tubes, they're printed on the side of the tube right here. So if the family doesn't know, you can sometimes look at the tube and see if it's there. Or if it's not printed there, if it's a different kind of tube or it's worn off, you may have to go into the chart and see if you can find it. Typically, it'll be listed somewhere within the medical record. So these are the kits that we use in RER. Again, it's the Mini is the brand name. They'll come looking like this, and there's a few components to note when looking at your kit. So your tube will be right here. There's a handy little stylet that helps with insertion. There's a smaller syringe, and we use that to help inflate the balloon. And then the larger syringe is used to test the placement of the G-tube. There's some lubrication to help facilitate placement, and then tubing to hook up when we go to check and see if the tube is in place. This is what the tube looks like when it's got the balloon filled up and not inside the kit. And just one cool thing to note about these mini tubes is they do glow in the dark. So this is a demonstration on how to replace the tube. We're using a cup here instead of a real patient, but this is the same steps you would take. So first you'll want to open up your kit. You'll be using gloves with a real patient. There's our little stoma you can visualize there. And so the first step is you want to check and make sure your balloon works because you don't want to put a broken balloon in there. And so we'll fill the balloon up with sterile water. It says how much water is used on the side of the tube. With these, it is 2.5 milliliters. Some tubes use more, but ours use 2.5 milliliters. So you're going to insert and then pull out the water after you've tested it. And then you'll lubricate up in a real patient. We're not in this one. And then you're going to push into the stoma there, remove the stylet, and then inflate the balloon to keep it in place. Now, once you've replaced your G-tube, you're going to want to check and make sure it's in good placement. There's a few ways we can check it. And the easiest one that we usually do first at bedside is by connecting the tube. Now, there is a lock, so you want to line it up and then twist it to lock it in place. And then you're going to open it up, take the larger syringe, and you'll aspirate first and see if you can aspirate any gastric contents. And then you'll fill the syringe up with some of your sterile water, and you're going to see if you can flush through the G-tube easily. And then once you've done that, you'll cap the G-tube or the tubing, and then you'll want to lock it just so that you don't spill anything while you're taking it off. And then you line the lines up to unlock it, remove the tube, and then close the flap. And your G-tube has been replaced. Now, this cup is sitting up. In a real patient, you're going to want to place them flat on their back in order to ideally position for replacement. So replacement should be painless. Now, occasionally it is anxiety provoking or uncomfortable. So a child may be a little worried about getting it replaced, or the young ones may be crying because, again, you're holding them down. Potentially they want to be sitting up and playing. They don't want to be lying on their back. And so they may be crying during that. But if they're acting like they're in a lot of pain, then I would stop doing the procedure because it should not be painful. Now, you do need some gentle but steady pressure to put it in. If the kid is crying, if it's a young child who can't follow instructions, they may cry throughout it. And so when we cry, we have increased pressure in our abdomen, and that can make things a little more difficult. Some things that can help: if you wait until they take a big, deep breath in, that belly will relax, and sometimes you can push that pressure in. Now, when you remove the stylet or you inflate the balloon, that should not be painful at all. And if there is pain with that, then the device may be out of position and within the tract. And so I would stop trying to inflate the balloon, or if you're trying to take out the stylet and there's a lot of pain, I wouldn't even try to inflate the balloon. And then I would call the surgery team to come take a look at it. Now, if you try to pass the tube and it's not wanting to pass, say the tube has been out for a very long time, then the other thing you might want to try is inserting a Foley. And so again, in the history, if you've noted that the tube has been out for a while, then you may bring some different size Foleys to the bedside along with your replacement G-tube. So start by trying to place the same French size Foley as a G-tube within the stoma. And if you're not able to pass, then try one size smaller until you're able to place the Foley into the stoma. And then you'll want to dilate the stoma up after that. So wait a bit and then replace with the larger Foleys progressively up until you're able to replace that G-tube. Now, as I mentioned in the video, there's a few ways to confirm placement. So the first one that we typically do at bedside is the aspiration of stomach contents and then flushing of the sterile water. If the G-tube has been long established, so the child has had it for years, and it hasn't been out for very long and it passes very easily, this may be all you need to confirm the placement, is that you can aspirate the contents and you flush with sterile water and there's no pain. But if it's a more difficult one, then you may want to do the dye study. So if the insertion was difficult or location is uncertain, then you do a dye study, and that's where we infuse contrast through the G-tube and obtain an abdominal x-ray. The other way we can check at bedside is we can inject air into the port while auscultating over it, but that one in the younger kids with a lot of noise tends to be more difficult, but that's another option. Now, if you do your dye study, this is what a good placement looks like. So you see you've got your dye within the lumen of the stomach, as opposed to this one where the port was, or the G-tube was not in the correct place. And we've got the dye kind of in this soft tissue here. And you can see it looks like a little more fuzzy. There's more debris. It's not as lined up as in our other one. And so that's a tube that has not been in place. So thanks for spending some time learning about G-tube replacement today, and hopefully the next time one comes in, you'll feel confident replacing it with the assistance of your attending.